Thank you very much. Actually, all the speakers really gave excellent lectures. We're going to take a few minutes for questions. Anyone from the audience? And my co-chair will collect the questions from the online. Yes, please.
Thank you for all the speakers. My question directed to all speakers about the correlation and relation of vitamin D deficiency and thyroid disorders. There is some trials showing that there is a relation between vitamin D deficiency and the sex thyroid. Also, vitamin D deficiency have some relation with autoimmune disease. So I want to listen for all the speakers about this issue, and it's not mentioned in all the study presented. What about the level of vitamin D of this patient included in the trials? Thank you.
Anyone would like to answer? Dr. Pierce, you would like to answer this question?
Sure. So I think vitamin D levels have been studied in association with every possible medical outcome that has ever been looked at. It's been the subject of an extraordinary amount of study, and it is plausible, certainly, that it could be related to autoimmunity. But I don't think there is any trial evidence that repleting vitamin D influences thyroid status. So I would say if you've got a patient who's vitamin D deficient, there may be, there are other reasons like bone health to replete it, but I would not expect it to influence the thyroid particularly.
Okay, thanks. Anyone? Yeah, please.
Yeah, I know that hyperthyroidism and pediatric is not your topic, but would you be able to comment on the choice of treatment for Graves' disease in adolescents and pediatric? I know this is not your topic, but maybe you can address some of them.
I actually don't treat pediatric patients at all. Christian, I don't know if you have any experience, and you may have more to add than I do.
I don't treat anyone below the age of 16. I do work or I do get questions from the pediatricians in the children's hospital. So pediatric Graves' disease generally is treated with anti-thyroid drugs, but it's more resistant. So the younger the patient is, the more likely it is that they'll have treatment failure. So they need longer treatment. For quite some time, we've been worried about giving radioactive iodine to children. And of course, we warn women that if we give them radioactive iodine, that, they should keep their distance from children. So it then makes it a little bit counterintuitive to start treating children. But I think most countries do treat children when they're post-pubertal. And so from 12 years of age, there's certainly quite a few centers that would give radioiodine in those that are resistant to treatment. But again, thyroidectomy plays a very important role in that population, certainly those with more resistant disease. There have been a number of trials looking at, so there was a trial published about 2 years ago that was done in the UK, where rituximab was used in children. So a single dose of rituximab at the time that they started anti-thyroid drugs. And that gave a hint that it was associated with better outcomes. I know rituximab has been used in adults as well. But so, to summarize, the mainstay is anti-thyroid drugs. Surgery probably plays a greater role in children than it does in adults, but radioiodine can be given, and the limited data we have on radioiodine safety in that patient population is that it is safe.
Thank you. Unfortunately, our adult patients start from the age of 14 for whatever reason, and that's we have
it's variable from one hospital in one region, and at our hospital it's actually 16 and above. So, okay, anyone from your side, Professor Maliki?
We have two questions. Online question for Dr. Pierce. So first question, what's your approach for management of those patients who develop transaminites up to 2 to 4 times the normal during treatment with carbimazole?
Okay, I use methimazole because in the US we don't have carbimazole, but they're effectively the same thing. I tend to monitor And again, I think it's really important to get the baseline liver function tests because often the transaminases are high at baseline. And if you have that and you know that the 4 times elevation was actually there before they started the antithyroid drug, I feel comfortable continuing to treat with antithyroid drug with ongoing liver function test monitoring. The situation's a little bit different if you know your baseline transaminases were low and they're rising, and then I tend to be a little bit more nervous and would probably consider another treatment option.
Okay, thank you. Second question, do you routinely refer your patient with Graves' disease for oculoplastic evaluation before radioiodine therapy?
I don't routinely refer every patient before radioactive iodine therapy, but any patient with any eye symptoms or signs, I do, because I do think it's important. And especially with the advent of teprotumumab, we have more options than we used to for treating those patients as well. So I think early introduction to oculoplastics is probably important.
Thank you.
And if we so patients who have very high levels of TSH receptor antibodies, those would also be patients where I have a lower threshold for referring them to an ophthalmologist, at least for an assessment. And it's usually together with the ophthalmologist that we decide which patients are going to have preventative steroid treatment. So again, that comes into consideration there. But those who continue to have high levels of TSH receptor antibodies, those are patients where even if there's little sign of eye disease, that I would have a lower threshold.
I have maybe a question for Dr. Pierce. Could you give an explanation why those with negative TPO antibodies seems to be more at risk for recurrence, like predictor for recurrence?
Yeah, it's interesting.
Thyroiditis is protective?
It seems to be protective in those data sets, and why that is, I'm honestly not sure. I don't routinely measure TPO antibodies in my Graves patients. I'm typically following the TRAB titers, so I don't really have personal anecdotal experience with this myself, but that is what the studies seem to show. And
maybe I have a question for Dr. Christine. In your experience, someone with pregnant lady with TSH above 4, okay, and another lady above 4 plus antibodies, would you treat both? Would you treat one or the other?
So I think our current thinking is more and more that we will probably treat when TSH is above the reference range, regardless of TPO status. I know the previous iterations of the ATA guideline very much made that distinction between TPO antibody positive and TPO antibody negative. I mean, I haven't seen the final version, certainly not of that section, but I think we're coming a little bit more away from that. But certainly in the fertility recurrent miscarriage population, when that TSH is above the upper limit of normal, and for many centers that will be 4, that will be treated regardless of TPO status. So yes, at this moment in time, I would. I can't hear you. I think you see.
Okay. I'm just referring to the study by Nazapur, and the Iranian study where they showed effectively that when you subdivide the group, because they have a population with a TSH between 2 and 10, and when they look at the subgroups, those above 4 obviously showed increased rate of premature delivery. And they advise really that probably this is a threshold. If you have trimester-specific values, use them. But if you don't, above 4 probably is the value to use. Correct?
Oh, yes. And so that indeed is what I do. So I have the luxury of having trimester-specific reference ranges, but I do that regardless of TPO status.
Very much, really. We had excellent speakers, and I thank you very much for the time you spent with us, and for you in the audience. Really, you're still resilient, and thank you very much for attending this session.